Hi everyone. In this presentation, we're going to talk about clinical dermoscopy and reflectance confocal microscopy evaluation of skin aging. To do so, we'll go through some of the aging features we can observe in the skin. We'll talk about dermoscopy and its ability to visualize pigmentation in vessels, and reflectance confocal microscopy and the ability to visualize the different layers, the epidermis, junction, and dermis, and the different features that we can observe with passing years. Then we will move to applications in terms of diagnosis and treatment monitoring. These are some of the skin aging features we can observe in the skin, and this includes pigmentation and erythema that can be very well visualized with dermoscopy too. But skin aging does not include just the intrinsic aging, the one occurring with passing years, but also the skin photoaging. And as dermatologists, we should be aware of the different types of skin photoaging that we can observe. These ones have been described in Caucasian skin, and they include the atrophic skin photoaging, clinically characterized by the presence of telangiectasia and an increased risk to develop skin cancer such as actinic keratosis, and the hypertrophic, characterized by coarse wrinkling with underlying dyselastosis, as proven with histopathology. But these features were also confirmed thanks to the non-invasive skin imaging tools such as the standard photography with automated features count and the reflectance confocal microscopy. And we can observe the distribution of the features in patients with atrophic photoaging in the upper part with increased amount of brown spots and red areas, and the presence in the patient in the lower part of the slide of a patient with hypertrophic skin photoaging being characterized by the presence of dyselastosis, as you can see in the white square appearing as curved fibers, as we will see later. So there are slight variations at epidermal and dermal level which have been related to the intrinsic and extrinsic skin photoaging. We can see here in this table that dyselastosis has been mainly related to the skin photoaging. So with dermoscopy, we were able to explore the skin with our dermatoscopes, and what we can see is an overall view of all the layers, right? But we know that, for instance, for the pigmentation, according to where it is located, we can see it in different colors. So when it is very superficial in the epidermis, we can see it as black. When it is located at the junction, it is brown. And when it is deeper at the dermal level, we can see it as grayish or bluish. And another thing that we can observe with dermoscopy, and we already mentioned that, is represented by vessels. But let's move to some example. Here we can see in this picture taken from the face of a lady of 40 years old, the presence of this pigmentation, right? We can see these areas of brown color which are related for sure to the presence of some degree of pigmentation at the level of the junction. And then we can also observe the vessels as related to the photoaging process. Then we have the reflectance confocal microscopy, and we know that we use this tool very much in the analysis of skin cancer. But when this tool is available, we can also easily apply also to the study of skin aging. And we performed many studies on this topic, and we were able to really understand some of the things that we're going to show later. So we start with the basics, and the confocal microscopy enables the visualization of the skin at different and separate layers, so we can see an horizontal view of the epidermis, of the junction, and of the dermis, the upper dermis. So we don't go too much deep into the skin, but then we're able anyway to observe some of the skin variations with the aging process. So we know that this tool is based on the refraction of the skin coming from different parts of the skin, and mainly from melanin. So we tend to observe as white the parts of the skin which are which contains more melanin, and then we can also have the refraction of the skin from some intracellular components, but we'll go through that. So to understand the variations of the skin occurring with aging, we should start with what's normal, right? So in the healthy skin, at the epidermal level, we can usually observe the presence of the honeycomb pattern, that is called like that just because it resembles an honeycomb. But some variations can be represented by these atypical keratinocytes, which are as a matter of fact, keratinocytes with different shapes and size, or another variations at epidermal level can be represented by the motile pigmentation, which corresponds to the presence of pigmented keratinocytes that can be observed in the skin. On the other hand, there can also be variations at dermal-epidermal junction, which can be represented by these polycyclic papillary contours corresponding to the presence of the pigmentation at junctional level, or pigmentation can also be observed according to the degree of the hyperplasia of the epidermis as the presence of ringed pattern. So, with confocal microscopy, we can also observe the dermal compartment, and in this case, Longo et al. Described in 2013 for the first time the presence of different collagen, the reticular, which is usually represented in young skin, the coarse, which is represented in older skin, as well as the huddle, and then the curd fibers. So the reticular, as you can see here, is represented by these elongated, these long fibers, very well crisscrossed and refractive, while the coarse collagen is represented by these thicker collagen fibers in bundles, and they tend to be also shorter and less crisscrossed. Huddle is represented as this roundish collagen, so not really keeping the tightness of the skin. And then we have the curd fibers, which has been shown to be related to the generation of elastic fibers and confirmed histopathologically. So the elastic fibers can be observed with confocal microscopy just when they are degenerated. The polycyclic papillary contours, so that we can observe in this slide, can be quantified. So with confocal microscopy, we are able to quantify the amount of a certain feature in a certain part of the skin. And you can see here as an example the presence of 2 per 2 millimeter square, in which we are able to identify 15 squares, smaller squares, and according to the amount of these, including the feature that we are counting, we're able to quantify, to perform, to understand the degree of the extension of this specific feature, as you can see here. And the same thing can be performed for atypical keratinocytes, for instance, as you can see in this slide. But the reason why we know that some of the features are more represented in younger skin or in aged skin is that we compare different age groups, and we realize that, for instance, the honeycomb pattern at epidermal level, reticular collagen at dermal level, were more represented in the younger skin in the younger skin as compared to the mottled pigmentation and the coarse collagen, which were more represented in the older skin age groups. So let's move a little bit to practice, and let's try to understand how we can visualize the pigmented lesions and how we can apply our tools in the diagnosis and treatment monitoring. So pigmented lesions can appear on the skin as single or multiple. And when they are single, we should be able to visualize the different features. We're going to talk about the approach that is now considered as gold standard, which is the inverse dermoscopic approach. But for sure, we know that we should be able to perform a diagnosis first, and then we should choose the most appropriate treatment according to the diagnosis. And we have different differential diagnosis when talking about pigmented flat lesions of the face, such as the solar lentigo, lentigo maligna, pigmented actinic keratosis, as well as, of course, the lichen planus-like keratosis. And we should be able to differentiate them with dermoscopy or other non-invasive skin tools such as RCM or biopsy, because of course these type of lesions are those lesions for which the patient will ask for treatment for macules removal, such as laser treatments and so on. So before doing that, we should perform the proper diagnosis. And we know that in difficult cases, we can actually use a confocal microscopy and sometimes a biopsy when needed. And in lesions such as actinic keratosis, we are able to visualize at epidermal level the presence of atypical keratinocytes, while on the other hand, for lentigo maligna, we are able to visualize the presence of atypical cells at epidermal level, and at the junction, as you can see here, on the right side, in the lower part of the slide, the presence of atypical cells also in the perifollicular area. They can also be extended to the interfollicular area, but of course you see some of these projection of the atypical cells coming from the perifollicular area going towards the external part of the hair follicle with the progression of the disease. So we already mentioned that we actually use for the lesions of the face, which is a difficult area to interpret with dermoscopy, the inverse approach. So this enabled really to improve our diagnostic performances in lesions of the face. And the inverse approach encompasses the exclusion or the evaluation of the presence of actinic keratosis features or solar lentigo sap-K lesions. And then if these features are not represented, we should always think about lentigo maligna. But we're not just called to perform a diagnosis before the treatment. Sometimes we also need to perform differential diagnosis in patients that underwent treatment somewhere else, in other centers, like in this 60-year-old man, which underwent two treatment sessions with laser of these macules, these pigmented macules on the face. And we see here the presence of a pseudoreticular pattern. And we can say that the colors that we can observe the most are brown and gray. And when we see the gray color, of course, in lesions of the face, we should always be aware that there can be a problem. But since the patient underwent a previous laser treatment, this can also be related to the inflammation process, right? So in this case, what we should do, we can monitor the patient after the laser treatment. We can try to understand whether we need to perform a biopsy Of course, we can move to the confocal microscopy, and here again we see the presence of these dendritic atypical cells, which are located around the hair follicles and also in the interfollicular areas. But mostly on the right side, we can observe the presence of single as well as confluent dendritic cells tending to form this junctional nesting. And the junctional nests in an acquired pigmented flat lesion of the face is related to the presence of melanocytic lesion and malignant melanocytic lesion, since this is a lentigo maligna, which was confirmed, of course, with histopathology. One thing that is interesting in this case is to remind ourselves that when interpreting lesions located on the nose, we should always be aware that the parameter, the dermoscopic parameter of the obliteration of the hair follicle can be barely visualized because of the anatomic areas that we are exploring. But of course, you can see very well here the presence of this junctional nesting and these dendritic cells that are surrounding the hair follicle and then spreading towards the interfollicular area, moving to the other hair follicles. And here a little a picture, so a little spot on the magnified dermoscopy, the 400 magnification that was taken in the same patient, and you can observe the rounded structures with projections in this lentigo maligna. Of course, the visualization of these features is can be really difficult for beginners, so you should explore the lesion overall, and then you might be able to find this feature that can confirm, of course, and support the diagnosis and the path of the patient towards final diagnosis. Pigmentation can also occur as multiple lesions, and the queen or the king of the diseases, or these dyspigmentary diseases of the skin occurring with multiple lesions is the melasma, which is considered anyway a type of skin disease related to the aging process anyway. And we know that melasma can be classified according to the most recent literature in epidermal and mixed, which means that the mixed ones has both the epidermal and dermal component. And while the epidermal is characterized by the presence of mainly of the brown color, the mixed one is represented by the gray color. And the hallmark feature of melasma is represented by the presence of the pseudoreticular network appearing in these two different colors as mentioned. The dermoscopic feature of melasma is represented by the perifollicular pigmentation with the perifollicular pigment sparing or increase in perifollicular pigmentation, as we're going to see here with these two cases. This lady, which the dermoscopic pattern is mainly represented by the light to dark brown pseudoreticular pigment network, sparing the perifollicular area. While in this lady, we can observe the prevalence of the gray pseudo network with the some periostal gray dots and periostal brownish gray circles in these mixed melasma, which was confirmed in both cases with histopathology. Sometimes it can be challenging to really distinguish among the brown and gray, right? So we can see kind of more prevalent brown pigmentation here. But if you have the confocal microscope in your department, then you can actually also apply to the melasma, and you can observe the mottled pigmentation at epidermal level and the presence of the ringed pattern at the junctional level. nothing is present at dermal level, which confirms and supports the diagnosis of epidermal melasma. And of course, we can use our beloved dermatoscopes also for the dermoscopic treatment monitoring of melasma, such as in this case of patient which underwent laser treatment, as well as we can apply RCM in treatment monitoring of melasma. And we published this paper on the overall applications of RCM in melasma, as you can see here. And again, you see the disappearance under confocal microscopy of the pigmentation at epidermal and junctional level. Of course, dermoscopy and reflectance confocal microscopy can also be applied to differential diagnosis of melasma, including diachronosis, which appears at dermoscopic level with this pattern characterized by grayish-bluish dots, and under confocal microscopy corresponding to the presence of melanophages, as confirmed by histopathology. But let's try to understand when we can employ dermoscopy to visualize the vessels in treatment monitoring. Well, there can be some applications. For instance, we can see very well the vessels on the face, right? So we can use this tool before and after treatment of telangiectasia of the face with neodymium-YAG laser. But the application is not just in treatment monitoring, but also in understanding which is the endpoint of treatment just immediately after neodymium-YAG laser, as you can see in this picture. Another application, in this case of confocal microscopy, is in the treatment monitoring of skin rejuvenation procedures. And we can actually use RCM to visualize the collagen and variations in terms of collagen. So you see here the clinical pictures of a patient before and after the skin rejuvenation with picosecond laser. And here you see the variations occurring in the skin before and 4 months after picosecond laser. And you can see that at the epidermal level, we have the resolution of the motile pigmentation and the restoration of the honeycomb pattern. While at dermal level, we can see something very interesting. So you see with the asterisks the presence of these elongated collagen fibers, very well crisscrossed. So this is kind of a reticular collagen that we can observe not at the baseline, but just after treatment as a result of the effect of the laser at dermal level. So we can see a kind of a deposition of new collagen occurring after the laser treatment. And this has been hypothesized, the correlation with new collagen deposition, in the papers by Longo and Pelagani too. So, other skin rejuvenation procedures that can be performed not just on the face but also on the body are represented by the biostimulatory fillers, and these fillers are injected just below the dermis, and therefore we can observe the variations occurring in the skin also with confocal microscopy, and we can see how the collagen appears more crisscrossed after treatment with the reflectance confocal microscopy. So this can be another application of this tool when it is available to the analysis of collagen. In conclusion, we can say that skin aging has been associated to pigmentary, vascular, and structural variations of the skin. And here we have our dermatoscopes and confocal microscopy that can be applied very well to study these variations. These tools are not just employed for the treatment monitoring, but also to the diagnosis, which is pivotal in our job of dermatologists. And so we can see how we can integrate our current dermoscopic knowledge to the practice in dermatology, which can vary and not just include, of course, the skin cancer, but also understanding how the skin varies with passing years and after the exposure to the sun, which is one of the major factors damaging our skin. And of course, we kind of understand now how we can actually study the mechanisms of action of the skin rejuvenation treatments thanks to the use of these tools in our practice. Thank you for your attention.